past employees, now retirees, we have medical staff, former board members, and lots of donors. So hopefully we're able to enlighten you on where we are today at the Woodstock Hospital. So Wayne, if you want to go next slide. Lights. Sure. So a little agenda. We'll go over sort of mission, vision, values, the team engagement framework, looking at the old hospital, new services, and a few other issues or topics that are fairly relevant to recent events at the hospital. So at the Woodstock Hospital, Wayne, next slide. Mission, vision, value, we're community-oriented, personalized and quality care. We're working together to advance health and the well-being of our community. We have values, which if you spell them out, it says circle, they're compassionate, innovative, resourceful, collaborative, leadership, and ethical. We strive to serve others, building on collective strengths, expertise, and shared values for the betterment of our patients, their families, and our community. So that's sort of our moral compass. One of the things that we've really worked on recently with COVID was around sort of the engaging the, making sure we had a communication framework. Through COVID, we actually had incident management team put in place where we had daily meetings and we set out daily communication to staff. There was a lot of events that were changing, whether it was around COVID testing or if you had COVID and what the rules were to return to work. So we essentially really worked on engaging in communication within the organization because a lot was changing fast and the old way of doing things wasn't really that appropriate. It's a busy slide. I'll just sort of sum it up in about 30 seconds. It's patient-centered care. So the focus of all of this is patient care. Cindy will be talking later on the slide. We've embedded patients on all of our teams within the organization. So we have patients and all the working groups within the hospital. And it's really about making sure we hear the patient's voice. And I'm sure during the questions we'll hear lots of patient voices. And also we encourage each of the department leaders to huddle. Some of the departments are daily. When you go to Walmart, you see them huddling. Our units are huddling daily to go over relevant issues. Management group meets every Tuesday. We're actually missing it to be here today, where we go over a half-an-hour huddle around any patient safety issues, any other concerns. We've actually invited board member each week to attend that huddle so they get an idea of what's going on within the organization. And the executive team, we go out and do what we call Heels Up. So we go out and visit staff, ask them some questions, and report back to the board what we hear on those Heels Up, we call it. But down at the bottom, we engage in quarterly all staff meetings. We do it virtually just because we're 24/7. It's easy to record that. If a nurse can't sleep at night, she just listens to our all-staff meeting and they're sound asleep. We invite our retirees back once a year, so many of you in the room here invited back for a barbecue and get together. We really are trying to engage the community through our newsletters, social media, and we have back to the board. There's a change in our bylaws where we're now a closed membership, and to encourage communication with past board members, we invite them back to an annual luncheon once a year just to give them a presentation similar to this. So it's really around engaging the communication framework and ensuring that all our stakeholders are updated with our current issues. Next slide, please. So we do safety huddles throughout the organization at real live on the unit, and that's to really talk about harmful events, near misses, patient safety, and any feedback that's in real time. So lots of communication on the unit. So that's a fairly new initiative. So before we get too far into the discussions, we always get talking about the old versus the new hospital, and Paul brought it up that he worked there just a few years ago. To give a perspective, the old hospital, when we left there, we were 103 beds, a $74 million budget. We're now 178 beds and a $165 million budget. Staff, just under 700, now over 1,200. Surgeries, 7,500 up to 9,900 now. And births have almost doubled from the 627 at the old site. ER visits, 30,000, now up to 49.5, and climbing many days. If we prorated that out, it would be over 50,000 visits. So fairly active and busy hospital. A couple of the new additions to the hospital recently. We do have a pediatrician. I've been at the hospital almost 26 years. I think pediatrics dates back to before I was there. Around 30 years since we were our last pediatrician. So Dr. Aslam's joined about a year ago and has been working with the Emerge and providing some support to that child and really sort of starting to develop that pediatric program. Pediatrics is a difficult area to recruit. Maybe not a concern here, not too many new fathers. But we have your grandchildren looked after. And really trying to grow that to 2, 3, and 4 pediatricians. Especially with the amount of births that we have at the hospital. We're continuing to recruit a psychiatrist. The psychiatrist department's seen significant growth in volumes as well. We now have 2 ear, nose, and throat physicians. We have 2 of those. And hopefully recruiting a new obstetrician within the next week or 2 to start in February. Pathologists, we're up to 3. Internal medicine, we put that slide there for Paul because in Paul's youth, he was one of 2, providing 1 and 2 on call. We now have 5 internal medicine docs. Now, Gary doesn't provide a lot of on-call, but definitely have lots of internal medicine. And we have the hospitals model that we embedded in about 5 or 6 years ago. Just a couple things on, we've added some permanent beds in 2023 to match our growth. We moved carpal tunnels out of the OR into a clinic so that we're able to expand our OR. We continue to optimize our mental health outpatient services. We have 24/7 RT coverage. We have a cardiac care clinic. I maybe won't read through them, but lots of new equipment and the DI. We have a new CT. We now do our hips and knees. A lot of them are 1-day stays. And we do, through Trillium Gift of Life, but we do organ harvesting for Gift of Life. We've really implemented IT dashboards, new medicine distribution units, and so lots of initiatives that we continue to work on within the organization. And when I say we, it's not Cindy and I, it's the other 1,198 that are back there providing excellent patient care. We're just lucky enough to come here and tell you about it.
Can you elaborate on the helmet program?
The helmet program, yes. So that's for children that come in with head injuries, and we give them a free helmet to take home with them. A lot of them fall off their bikes and bang their heads, so it's a free helmet program. And you'd be surprised at how many visits we have to the Emerge because of that. So, yeah, so we give them a free helmet. Because often they use the old helmet still, and they shouldn't. So, or they weren't wearing helmets.
I see most kids do though.
So we do, you've probably heard us talk about the new Corey robot. So we're the 7th hospital in Canada to implement the robot, and only the 2nd in Ontario. Beside LHSC has the other robot. And that does some imaging of the knee placement so that there's limited, not an orthopedic surgeon, but there used to be a bit more of a handcraft to how you put your hip and knee in. This does a measurement and then tells or helps aid the physician on how everything should be placed. So should lead to quicker recovery and less pain. We just went live with our new CT scanner about a month ago. We purchased a medical building at Athlone and Finkel with some of our reserves. The building got about 15,000 square feet of unoccupied space. So we're looking and working with, and Roy would know this, our functional programmer back in the day, 25 years ago. We've re-engaged them to talk about a 5, 10, 20 to 30-year plan for space. We have a meeting this afternoon where we're going to see the first iteration of that. And I had a few meetings to really discuss the statistics and growth of the community. So we're looking at taking some sort of an outpatient service, putting it into the new medical building. It's half occupied. The tenants that are there are paying rent. So with that rent, we're able to cover the operating costs. And with the new space, then maybe expand, whether it's pediatrics, surgical service, or something in the main hospital. So we're working on that. We're hoping to have something to show the board in December and eventually to the community in 2024. You'll hear more about that. We are very proud of our energy initiatives. In 2019, we installed a combined heat and power cogeneration plant. So we burn natural gas to produce electricity, and we're producing about 85% of our own electricity. We had initial outlay of 4.2 million. We got a grant for 1.6. Cost us 2.6 million, and we have a 5-year payback. So it's almost paid for itself, and yeah, quite an initiative. We also put some rooftop solar on the medical building that we built about 10 years ago. $250,000, a 12-year payback, and expected life of the solar panels is 25 years. And we're producing, you can see the picture of them on the roof, about 50% of the power we use in the medical building. We put some car chargers in with a grant, so and believe it or not, those are being used to the point where staff are having to go out and move cars. There's a higher adoption rate of electrical cars, so it's good to see them being used, especially in the merge parking lot where the physicians fight for the. Lots of recycling. We recycled our N95 masks, collections throughout, so we're very proud to be involved in recycling. We've done a lot of work. If you've heard through the Ontario Health Teams, that's sort of they were established in 2019, and that's really bringing together primary care, home and community care, and a number of the providers to really try to work on providing navigated care and seamless care to patients. There's some work to be done on that, but we have done a lot of work with some of our community partners. We've signed a hospital and police transition agreement. So that's really around police are out in the community, there's social workers riding in their cars, and we really worked on establishing parameters for when a mental health patient would come to the hospital versus be seen at CMHA versus not being treated in the community. So we've done a lot of work, and it's really helped with the handoff of police to mental health patients in our merge, and also helped bringing the right people to the right location. I think at this point I hand it over to Cindy.
Thanks, Greg. So I'll kind of go into the nursing perspective and kind of the patient-centered care, because obviously that's my love, obviously. So recognizing with COVID, obviously there was a lot of staff that left, right? I mean, the older nurses retired, and there was recruitment challenges for sure. So we put a lot of focus into recruitment now. And so one of our big focuses, I won't go through all of them on this slide, but a few that I'll highlight is the nursing extern program. So 2 years ago, actually, we initiated this where the nursing students actually got hired for the summer. They worked somewhat similar to a PSW, but they could do a bit more than that. And they were able to support the nurses on the units as well. And it was a great program, and actually it kind of sells the hospital. So that was our initiative behind that. So initially we did it only on 2 units when we started, and now we've expanded it to the medical, the surgical, the rehab, the complex care units within the hospital. And so we actually had 22 students this past summer. The first year we actually asked them if they wanted to stay afterwards, if they wanted to stay on, and we could kind of keep them on just working on the weekends, etc. Most of them went back to school, so they said no, but this year actually we've actually been fortunate to be able to retain 9 of those. So they're working every weekend essentially, or every other weekend, and still supporting the nursing staff, so it's great, and the patients actually are saying that they love them there as well. They're just the extra pair of hands essentially, right? While still giving them somewhat of an experience. We've increased marketing. You've noticed if you have Facebook and any kind of social media, right? We've posted a lot of things on social media now to try to sell the hospital essentially, and to get new hires there. And then we've also started to do with our new grad initiative again. So when I started, way back when, there was a new grad initiative, and that guaranteed a nurse a full-time position essentially, mentored for 6 months essentially. That was kind of went by the wayside because the government then said you had to guarantee a full-time position afterwards. So there was a bit of change behind that. So we've actually, now they've changed it back again, and so we actually have been able to do some new grad nursing initiatives again, and they have actually been successful, so it actually kind of gives that mentorship phase again. We've also done some internationally trained nurses. I know that there's lots on the news and stuff about internationally trained nurses and making sure that they can come here quicker, and so we've been able to do those. We've only actually been able to do 2 successfully. just because of some of the language barriers, etc., and some of the staffing challenges to be able to support these individuals. We continue to do Discovery Week for physicians in training, and that's been a very successful program as well, where the residents actually come to Woodstock, they look at the community, etc., and we've actually had 2 family physicians actually move to Woodstock as a result of that, so that's a good initiative. Moving on to retention, so recognizing obviously with COVID again, we struggled, the new nurses struggled, they struggled with just being on the floor, etc. So we put into place, and actually we were one of the first hospitals essentially to put in place a clinical coach. So what this was is actually an individual, a seasoned nurse who actually went on the floor with these new hires and stuff and was at the elbow support with these individuals. So initially we were seeing a lot of nurses leaving the profession, especially new ones, because they really hadn't done anything in nursing. And then now that we put this clinical coach in place, it's stabilized our workforce, so it's a great initiative. Then the government actually recognized as well that this was a great initiative, because we actually told a number of hospitals that this is what we were doing, and they've actually given us funding actually for some clinical scholars now, so it's a great. We've initiated a float pool, which just helps cover some sick time, late career nursing initiatives where the nurses can actually reduce their shift by 1 each rotation so that they're not having to work as much, which is great retention. And then obviously the big thing as well is having volunteers return, so that's a huge thing. Staff are feel very supported with that. Recognizing that there's some diversity in the community now, right? So we have developed our diversity and inclusion and belonging committee, and we actually have 19 members in the hospital that are actually on this committee now. We've done some training as well around LGBTQIA training. We've developed a smudging policy, so that was one of the initiatives that we have done, and it's just because we did have a number of Indigenous patients that actually came in and requesting this. We didn't have a policy before, so we've actually developed that now to meet the needs. We did do 1-page summaries for staff so that they know kind of what the traditions are around certain demographics. And then we also did some Sikh heritage education as well. I think Perry alluded to this, so commitment to patient-centered care. So myself and our patient experience lead actually go around and actually interview at least 30 patients per month, and that's just to get feedback on how we're doing. Can we change anything? Is there something that is really bugging them that we could change in the moment? And so it provides us very good feedback. We also engaged one of our past board members. I'm sure she won't care if I told you, but Beth Taylor, and she's also doing these surveys as well now. So it's giving a different perspective because she's not employed by the hospital, so they can actually feel, I think Jen and I are pretty easy to talk to, so I think that they're giving us good feedback, but when there's not, essentially you're not hired by the hospital, it does provide a different feedback. We do have a patient and family advisory committee, and as Carrie alluded to before, the patient representatives are on all of our hospital committees and actually on the board as well as a voting member now, so that's a big thing. It is a provincial best practice actually, so we are one of the leaders in that. They've also been involved in a number of other initiatives, the chemo renovation project, which I'll talk about a little bit later, and they are actually going to start to attend our departmental huddles as well. So the PFAT committee, thanks Wayne, you're just clicking me along here. They do meet, this is a group of individuals that actually meet every second month, and they meet for about 90 minutes. We kind of give them an overview of things that are happening at the hospital. They also provide feedback on policies, education, and hospital initiatives. So it's their voice essentially. We currently have 19 family advisors and 10 staff members that sit on this committee. And if anybody wants to become a PFAC member, please reach out because we are always looking for more individuals as well. So. Talking about emergency wait time, this is a big thing, I know, and it's a big thing on the news, etc., about the amount of time that people wait in emergency departments, even after they're being admitted. They sit in the hallways for up to 16, 17, 18 hours. I'm very happy to say that we are currently number 2 out of overall performance of 73 hospitals. So we do get funding associated with that as well, and it's called our Pay for Results funding. And it looks at these key metrics. So it looks at ambulance offload time, so that's from the time that the ambulance comes into the organization till the time that we actually take the patient off of the ambulance stretcher and into a bed, and then they get to go on their way. So we actually do very, very well. The target is less than 15 minutes. Most organizations are much higher than that, and we're actually sitting at 20 minutes. So and we kind of chip away at it as we go. Our physician initial assessment time, our time to inpatient bed. Time to inpatient bed, we are number 2 in. That one is from the time that the physician says you're going to be admitted to the hospital. So from that time to the time that you're actually in an inpatient bed on the unit. And then obviously we look at the ED lengths of stay as well. So I'm very happy to say that we're rated number 2. In regards to some patient feedback, we actually looked at the emergency wait time. And so the feedback from patients was, you know what, we don't know how long we're going to be sitting here, and we kind of want that knowledge essentially. So this is just some transparency to the patients when they're sitting in the waiting room. So how long is the longest patient to be able to see the physician? So this is up on a TV screen in the emergency department, and it kind of gives patients kind of a general rule of thumb on how long it's going to be. What's happening, is there ambulances in the department, is there holds, etc. So that kind of gives that transparency. There was an ask at one point to put it also on our our external website. The problem with that is then too many people, not that we can't say we won't want people coming, but then it really just draws it in, right? Because I mean, London's wait times are significantly higher than ours. So initiatives coming soon. So again, related to patient feedback, TVs was a huge issue. So I'm going to admit that our TVs in the hospital were not great, right? They've kind of outdone what they've outlasted what they were supposed to be doing. So we've actually gone to a new system, which are going to be installed in December, starting in December. And so these are all the wonderful things that this new TV will have on them. So we did go out, Jen actually went out and surveyed the patients, said, what do you want on a TV? We actually had a number of vendors that they could actually look at, and this was what the patients essentially picked, was this Panacea. So we'll be able to have patient education on there, they'll be able to order their meals on there, we'll be able to do some surveys, etc. on there, so we're very happy that that's coming. Because I'm telling you, the number of complaints about the computers were high. I mean, about the TVs were high. Another initiative coming soon is the chemo infusion clinic redesign. So essentially, we outgrew our space in the chemo area. So we actually did engage with patients as well on kind of how they would like to see their space. So we do have 2 patients who were actually, they're no longer patients, they're just on maintenance doses of the chemos. But they actually were very involved. They actually went to site visits, etc. We did a mock layup so that people could understand what it would look like. And we're hoping to start that in April next year. Yeah, so that's kind of so we're in the process. So we'll go to 15 chairs from 8. And then, obviously everybody knows Woodstock Hospital 50-50. So we've raised over $2 million. These are just some of the things that we've raised the money, or that essentially those people that are purchasing the tickets to raise money for, is the ultrasound machine, the fluoro, and the new CT scanner, which Perry talked about. So thanks to the community, for sure, we could not have done this without the community's support. And that's it.
Yeah, I got it. In your emergency waiting room,
Yeah.
you should revise the layout.
Okay.
Among the people that was suffering, I've been there 3 times in the last month, we had a big laugh. 2 wheelchairs located exactly where the people has to come out from the circle. And it was very, very interesting to see how people would climb over the wheelchair. Now, that was not acceptable. Congratulations, the hospital is the best I ever seen. I've been in 4 or 5 countries myself, and I never seen anything like that. So congratulations to the management too.
Yes, thank you. And it's really the frontline people that are doing all of that, right?
But have a look when you have 2 wheelchairs.
Yes.
Then you can have a big laugh.
I just wanted to ask, recently we've seen a lot in the paper and newspapers of the cyber attacks in hospitals southwest. think maybe Windsor, if I recall. I'm always wondering how that happens. Like, is our security, I'm talking in general terms, in hospitals, is our security just always open to somebody poking a hole in it? Or can we do better? And what's ours like?
Yeah, so that's a big topic, and it's probably one of our bigger fears, because it's not just the city of Woodstock, for example, the listable Wingham hospitals, the number of Toronto hospitals. So I can say to you, the provincial government mandated a few facilities. So in our area, Southwest, it's LHSC, where they were given some money to start to develop, because really the number one security, look at banks. Banks, I think if we do some sort of scoring, they rank a 5. Hospitals are like a 3.2 or 3.3. So we're trying to get there. So London got some money to do some regional security analysis. So we joined in with that group. They came and did an audit of what we have for infrastructure, and also paid some people to take a look at it from the exterior, but what our vulnerabilities would be. So we have done some changes there. We scored very well. So there's that whole governance piece that they're really looking at the infrastructure, but it really comes down to staff and their practices. So we also do what we call phishing exercises, where we relax our security. London doesn't even tell us, but they'll tell us it's happening this week, and they send out an email on a phishing exercise to see if staff would answer that. The first couple times they did, we had about 10% of staff actually click on it. So we've done education, and we redo that every quarter. And the email looks pretty official, because they'll do a topic like, during COVID, they sent out a phishing exercise saying, please validate your COVID hours. So everybody wants to validate their hours. And so we're doing that internally. We've also built in some redundancy, because the other way you've got to look at this is, if you do get attacked, how are you going to respond? We have over 200 softwares that we use at the hospital, so we went through and ranked them. When I say we, the IT department with the developers, what would be mission critical, so that if we did get hit, we knew where we would start rebuilding or developing to turn the lights back on. And also, we've got a disaster recovery plan. We have some equipment in our medical building that's about 10 years old, and we've practiced that occasionally, about every 6 months, of doing a disaster recovery. So it's multi-pronged, but it is an issue. I can speak, I haven't really talked to many of the CEOs in Erie St. Clair, because they're being busy trying to get their hospitals operating. But in Listowel Wingham, how theirs happened was, they were putting in a new health record system. They put it on an old server, and they were just trialing it on this old server, which had a gateway into the main servers. When the project went live, they forgot to shut that server off. Fast forward a year or two, they're doing updates and sophisticated stuff to the current servers. They left that one alone. Hackers got in through that device and in. So it's a bit of a due diligence. We've also ramped up, back when your day, Roy, we used to have all the emails go through a filter. We've done that, and even after hours, we have a monitoring, because a lot of them will attack your websites and get in that way. We have a company that monitors at night, because our IT department's got to sleep at some point, and will alarm us if they see some weird activity, and potentially even shut our website down. So there's lots of stuff happening behind the scenes, but usually it's just like your house, somebody leaving a door or window unlocked, and in they come. And it's relentless.
Harry, I just have a comment on this new CAT scanner. I had the privilege of Sunday morning at 9:10. I had a CAT scan scheduled, and commended to that, running outpatient CAT on weekends. I always thought that the hospital business, if I knew about it, near Saturdays to Sundays, not doing anything. But anyways, it took me longer to get on the CAT scan and off it than it did to actually have the scan. It was like less than a minute. And the report was available to the physician at 10:30, read by a radiologist somewhere. And so it's
Yeah, most of our DI reports are read, like if you're there on a business day, that morning it's read within 4 or 5 hours, usually guaranteed within 24, even on weekends.
Yeah, in my time, you had to develop the film and.
Yeah.
2 or 4 days later, you might find out you got a broken arm.
Yeah, if they didn't lose the film. The other comment there is, you're a slender build, so you probably had lots of room in the magnet. The hole's a little bit bigger, so that if you want to keep eating dessert, there's lots of room for you. You don't have to water me up anymore. Yeah.
How do you see, what is the biggest challenge you face with the Woodstock growth? Are you able, say, handle not 15,000 people as projected?
So that was to my comment earlier, we run the functional program back. Because we know anything they develop is going to take years to get, and even with the original hospital, when the old hospital is 100 and some years old. So we have to really sort of stay attuned to what that growth is. And it's not just growth in Woodstock, it's all the surrounding communities, whether it's Interkip, Hickson, they're all growing, and we have to make sure that we have our eye on 10 and 15 and 20 years out to advocate to get the capacity. Because we're finding that now. When we first moved into the hospital, we were a lot more beds, and the occupancy rate wasn't that high, but today, most days, we're running almost at 100% occupancy, which puts pressures on the system, right? It's not ideal.
Harry, I've heard a couple of people say that there's no room to build. They made a terrible mistake when they built that hospital. There's no room to expand. Want to speak to that?
There are expansion points out through the DI and out through the affluent entrance. I'd say the bigger issue will be parking. It's already been an issue where we expanded our parking lot a couple times. So we'd probably have to go some sort of parking garage or something. The design of the hospital is like an airport with the fingers out, as we all know. It does make it difficult. It has used a lot of space, but there are a couple expansion points. Sorry, this gentleman, yeah?
I heard on the radio recently that the province is funding private clinics to do, I'm not sure if they're routine surgeries or the broader spectrum of surgeries, and actually paying a higher rate to those private clinics than they're allowing funding to our hospitals. What is your take on that, and is there anything that we can do to be involved in resolving this?
So to Roy's point earlier, I think we should really investigate doing more evening and weekend work at the hospital before we looked at putting something in the community, because we do have all the diagnostic tools in place. And I think in terms of that CBC article that I heard this morning driving to work, that's a discussion about average cost versus marginal cost. Our cost to do an extra case isn't that high because we have the infrastructure in place. But if you're to set up in the front room of the Legion a scope clinic, you have a lot of capital costs that you have to incur. So you would have a higher cost per case. So we'll take more money if they want to give it to us. But that's sort of the discussion, and from what I understand, there hasn't been any discussion in the community here about public surgery or outpatient surgery.
So are you suggesting that there is capacity that is being unused in the hospital now?
So that's part of our growth plan. We have right now 4 ORs that are utilized, probably, well, they are business hours, they're utilized. We have a 5th ORs where we do C-sections, so we have working through a functional programmer of maybe making that an operating room and creating a C-section room somewhere else so we could go up another 25% of our volumes. And it's sort of staging that also that we make sure we do it in such a way we're not undoing something in 5 or 10 years.
So are you're going to do this? You're going to expand the use of the operating facilities?
That's our plan, yeah. Over time we need some, it's not just Cindy and Perry's harebrained Saturday morning idea, with some sort of evidence, empirical behind why we're doing that. So, sorry, I'll go here and then over to you, Doug.
Yep. I just wanted to make a comment, having had experience at the hospital this year. Had both knees replaced, and I found that the surgery was excellent. The patient care was wonderful. They don't keep you in bed, obviously, for good reason, and down to the physio facility and the people there were all top notch. slightly negative side, my wife was in the Emerge twice, or has been twice this year. One time we left after 4 hours because the weight clock, the dial kept moving farther and farther and farther forward. And we ended up going to the after hours clinic and got diagnosis that she already kind of knew what was going on. But the second time she went, she was seen almost immediately, and even though we were still there for 3 or 4 hours, you know, went through X-ray and CT scan and blood work and all of that stuff. Bang, 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 bang. It was very efficient.
Thank you.
Oh, yeah, works great.
You had mentioned extending the hours of operation to a second shift or however you do that. What is preventing you from doing that now?
Funding and when Cindy talked about staff, there are hospitals, and I don't want to point them out, but close to us here that are using agency nurses. So that's nurses that just drop in, well not just, but they come in and work shifts for a week. We would have to, our OR staff isn't, we don't have enough capacity with our current OR staff to expand that, so we have to develop. We have done grow our OR nurses, where we've solicited nurses to say, hey, we'll provide you the education, you want to go work in our OR. So we would have to beef up our staff. There's also an anesthetist and funding. So, but that is the way, with volumes keep growing, we'll have to address it.
And the ministry is looking at that. I mean, I just had to fill out a template on kind of how we could expand. So what would that look like? What kind of staff would we need, etc. They're not guaranteeing any money at this moment. They're just saying kind of what organizations can do to actually serve our time. So hopefully that will come.
Sorry, stupid question. Does the hospital have any debt and is worried about refinancing?
No, the hospital's in great financial position, and I point to some people in the room that handed it that way when they retired. We've kept it on. We're very physically responsible, and a lot of that is.
The hospital doesn't borrow money on shorter, long-term basis to expand?
No. We have capital reserves. We have money in our foundation. So, and you can tell by the equipment that we purchased, there's not an issue. Hopefully, there isn't an issue that we're dealing with outdated equipment. I know a number of hospitals, without getting into a 2-hour discussion, have had cash flow issues, and one hospital to the north of us here has delayed the replacement of the CT scanner because they don't have the money. We do. We can buy the equipment that we need. And it's thanks to many of you in the room. It's our 50-50, and we've been very fortunate.
We have one more question.
You pick.
I don't know.